technology figured out here. I want to reintroduce Dr. Boyle, Dr. Michael Boyle. He's going to be talking about how to provide the best care for adults with cystic fibrosis. So please help me welcome him back to the podium. Oops.
Should we get 1 minute of, should we get started now? You want to take 1 minute? I guess, wow, that got quiet. Okay, great. Everybody stood up who wanted to stand up? Walk around your chair? Okay. Well, thanks again for the invitation to be able to speak. What I was asked to talk about for this talk is actually something that's maybe a little more, not too many scientific graphs. There's a couple, but really it's the idea of how can we, as caregivers and patients and families, work together to try to form the best care team and get the best outcomes for our loved ones, ourselves, for our patients with cystic fibrosis. That what I'm going to actually base a lot of this talk on is two things. One is a project that I'd helped lead, which was called a benchmarking project or a quality improvement project, which we actually visited top-performing centers in the United States and looked at how they were doing their care. And specifically, we'll talk a little bit about how we did this, but tried to come up with some key points that we thought were helpful and at those centers that had the best outcomes. And then also talk a little bit just about our own experience. We're not going to pretend at all to have the corner on the market on good care or all the secrets, but we've definitely, in the last 15 years of running an adult program, learned some things that I think are key in trying to provide the best care and form the best partnership. We actually have one of the largest adult programs in the country. My team and I take care of about 300 adults with cystic fibrosis, and so I'm going to base some of my comments just on that experience. And that during this time, hopefully talk about three things. First of all, to try to convince you that what we do makes a difference. You know, the question sometimes is, does what we do actually make a difference, or is this really all genetics? If you have good genetics, you do better. If not, you do poorly. I'm going to try to convince you the answer is yes, it does make a difference how we approach our care. Also, how to partner with your caregivers to assure the best possible care. And so this is going to be a little bit more aimed at well, I shouldn't say it's just adults. There's a few more adult-type things in this section, but it could also be parents as well. And then lastly, this idea of strategies to help young people with CF become successful adults with CF, because one of the requests was to talk some about transition from pediatric to adult care. So let's start with this first thing. Does what we do make a difference, or is it all genetics? So what I'm going to do is actually show you a couple of things to convince you that genetics play a big part, but what we do in terms of clinical care makes a big contribution as well. This is actually the review of a study, or this was actually the publication of a study from Gary Cutting, who's a geneticist at Johns Hopkins, specifically looking at the effect of genetics on lung outcomes in cystic fibrosis. And so what he did was to look at the similarity of lung function and nutritional status in individuals who were identical twins, so monozygous twin pairs, so identical twins, and compared those to who were non-identical twins or age-matched SIBs. And the difference between these are that this group has identical genes, right? This group has on average about 50% of their genes the same. And so by telling the difference in how similar those two groups are in terms of their outcomes, you can tell a lot about whether this is all genetics or some of it's also other things. And without spending too long on it, the bottom line was when you looked at monozygous twins and compared twin A and twin B in terms of their lung function, they were actually remarkably similar in terms of their lung function. And they were more similar than those who just shared 50% of their genes, meaning non-identical twins and brothers and sisters. And so their conclusion was that our heritability estimates indicate substantial genetic control of CF lung disease severity, something we already felt comfortable with. But as you dig into this a little bit more, because if you looked at this, you'd say, hey, it's all genetics. If you look into this a little bit more, you start to actually see there's a mixture between genetics and clinical care. This is actually a very commonly seen thing when you started looking at these individual pairs. This is an identical twin pair that was followed throughout the study. This is the lung function of the first twin and the second twin. And you can see that during the early part of their life, a lot of their lung function was remarkably similar, right? They almost look like they're right on top of each other. But as soon as they moved away and moved apart, they actually had a pretty different course in their lung function. And this was seen over and over again to the point that if you look at how similar twins are, identical twins are, when they start getting into their adult years, there's actually a lot more difference, and that's than when they're living together. So when they actually did some scientific or statistical evaluation, they found that there was about 4 times more variability when twins were living apart than when they were living together, suggesting it's not just genetics, but it's also the other things that are going on around. Care, where you're getting your care, how well you're doing with your medications. So we used to say that, I'd actually presented these data a little bit while ago, maybe some of you have seen this before, we said that one thing we could do would be to assign one of these to all the patients as they go into adulthood. This is a classic mom with a little different apple pie than normal. You know, sort of mix this all in. This is exactly what we need. There's the recipe for like the perfect lung function. But I think one thing as we think about this is that, you know, this is the year actually when there are going to be more adults with cystic fibrosis in the United States than kids. If you look at the current projections, the 2012 is the year where more than 50% of individuals with CF will be 18 years of age or older. So what may be a more, rather than the mom, might be a little bit more would be to start identifying sort of inspirational adults that really maybe say, hey, this is one of the ways that we can make sure that we're building and preparing for this successful future and not just relying on mom and apple pie, but really sort of a partnership. But anyway, this is probably a future. The other thing is there are some data that suggest that how well you do with your medications influences how often you're sick. This was actually from a study at Johns Hopkins that we did where we took 95 of our patients, some from pediatrics, some from adults, and we followed them clinically and also their pharmacy records for a year. And so we didn't just ask patients, how are you doing with your medications? We actually went to their pharmacist and found out how often are they actually filling their prescriptions. Since we know that that's not always the same answer, this was actually just looking at what we developed this thing called a medication possession ratio. This doesn't prove that you took your medicines. This just means that you actually at least had the possibility of having them in your cabinet. So we went through and said if we were supposed to be taking Pulmozyme once a day for 365 days a year, how many did you actually fill at the pharmacy? And when you look at these, that on average, it depended on the drug, but only about 70% or maybe 75% of the medications for azithromycin were even filled. All right, these are the median. That for Pulmozyme, it was about 70% was filled. That means that's the most that those patients could take, right? Because they didn't even have more than that. And that hypertonic saline was even lower. This is a couple of years ago. But this sort of highlights how there's this variability. So there were some patients who got all their medicines, and there was also some that when we looked, they really, truthfully, weren't filling it at all. But here was the part that I think was so striking. When you went back and looked, and you divided these medication possession ratio into groups, that those who actually had medication possession ratios that were on average up close to 80%, I guess there's a couple different ways of looking at this, but those who had no pulmonary exacerbations during the last year had an average MPR of nearly 80%. Those who had 1 to 2 pulmonary exacerbations, about half of their medications. The group that was sick 3 or more times actually filled on average less than half of the prescribed medicines they're prescribed. So I think this is just something that again gets into this whole point of what we do makes a difference. There's more than just genetics. There's also, we want to make sure that we build a partnership which allows us to do the best job of sort of forming a support network and making sure that people get their medications. So the answer to this first question is, does what we do make a difference? Is a resounding yes. Whether we look at it from a couple different ways, the answer is we have to make sure that we do a good job of building a support network. So the next question is, how can we partner together as caregivers and family members and patients to be able to basically assure that individuals with CF are getting the best care? I'm going to base this some on this adult CF benchmarking project. What we did was we actually used statistics to identify the top 10 adult programs in terms of their lung function over the 5 years previous to this. So we looked at basically rate of decline during that time. And we actually visited all 10 of these centers. We did a questionnaire to capture details of the clinical practice. We interviewed the team members. It's complicated, right? There's a lot of things that go into care, but what we were trying to do is to look for trends and to look for things which stood out. And then try to summarize these across groups. We actually did, through a summary, compare, these are each individual CF centers adjusted for FEV1, so adjusted for things we know influence the age of individuals on average for the program, whether or not they're pancreatic sufficient, things which we know influence severity of lung disease. And we actually ended up visiting all these centers that are in yellow. Again, these were the best performing. And then at least surveying, we actually surveyed everybody, but we particularly got surveys from some of these other centers who weren't performing as well and tried to say, can we see a difference between their approach? So I'm going to just highlight some of the things which stood out. So a couple of things, centers with best outcomes, this is going to be the theme here. We're going to talk about centers with best outcomes, what they do, and then what we can do as family members or as patients that would go along with that. So centers with best outcomes, one of the things they do is maximize the use of clinic time. Clinic time is actually a very valuable time, right? Something you go to a couple times a year, a handful of times a year. You want to make sure that when you're there, that you really are using that time as best as possible. So centers with the best outcomes tend to have preparation for clinic visits. They didn't just sort of have the person show up, but they'd actually prepare, oftentimes with the whole team, including a social worker here or a dietitian, physicians and nurses saying, oh, here's some of the things. We had a hard time filling this prescription because of insurance issues. Oh, their vitamin D is low. We need to do this. So that when that person comes into clinic, we can really make sure you don't miss the details, because we all know clinic's busy, and if you're not prepared, it's easy to lose those details. So what does this mean for family members and for patients with CF? I think patients and families with best outcomes, they're going to prepare for going to clinic as well. If you just sort of show up and sort of expect, it's easy to miss those details, or to say, oh yeah, I forgot to ask that question, right? And then that's a missed opportunity. So what I would suggest is, and what we've encouraged our patients to do, is have a list of key questions or issues to address. That actually like it when a patient comes in, they have a list of a couple things that they've been thinking about, or questions that they have, or concerns that they have, because that allows us to it's in an organized way to go through those. The other thing is almost every parent, every individual with CF has some ideas about ways that they say, I wonder if this would help my health. This is the perfect time to bring those up. So we actually, I just had this in clinic last week where a person said to me, I have on my list, I have one thing, and that is, do you think I should be getting a chest CT? And so we talked about that, and the answer is I loved the idea. They'd actually had one a couple years beforehand. It's something that we use from time to time as a way to monitor progression of structural lung disease. But truthfully, I wasn't going to order it because I was just sort of busy with all kinds of other things, and they brought it up and said, I feel like it's been a while. So we said, what? That's a great idea. Let's go ahead and do that. Go ahead and get that. We'll do it before your next visit. We'll look at it together. It'll be one other way. It also sends a signal to your caregiver that you want to be aggressive, that you want to do. I can tell you as caregivers, a lot of times we're a little hesitant because you've already given a list of 4 or 5 things. You don't want to make it 6 things. But sometimes if you say, I'm interested in doing this, I'm interested in following through on this, that sends a signal to your team that you're willing to do it, that you're concerned about the details, and it forms a partnership in terms of getting the best care. For parents, I think you have to start teaching your kids this from an early age so this doesn't become the parents' or the mom's illness, right, where they're the ones who know all the details, so that from an early age, the idea of discussing with your child what they think should be discussed at the next clinic visit. This teaches them to start recognizing symptoms, make sure it's not just a visit for doctors and parents. Centers with best outcomes also, from our study, involve patients in their care by regularly giving them feedback, particularly by showing them a picture. So this is one of our favorite things. So I'd say patients with best outcomes and families with best outcomes should know and understand their data, to have some ownership of that data. So that means knowing your lung function, your FEV1 trends, knowing what's going on with your weight and your BMI. Microbiology is a big one. You should know what's going on in your lungs. You should know and expect to know when new things pop up and discuss what's the right approach to that. Also, there's key labs. If you have ABPA, you want to know what your IgE level is. If you're treating your vitamin D, you want to know what your your 25-hydroxy-D is. So you can start to learn those things and help follow through. And then sometimes radiology is helpful because we all learn from pictures well, and we'll talk about that. This is something that we've used with our patients, is just to give them feedback in terms of their lung function over time, their nutritional trends. Graphs are helpful. If you're not getting one, then maybe the idea would be to go ahead and create your own graph. It's not that hard. Some of our patients, tends to be the engineers in particular, come with these incredible graphs, and I say, oh, wow, look at that. But something simple goes a long way. So if you're not being provided that, I think you want to come up with some way to be able to figure in your mind, am I better than last time? How's this compare to where I've been? To help decide about whether or not what you're doing is working. We actually frequently do what we call chest CT interventions, and that is in young people, give them a picture to look at to help them understand why they are doing that hypertonic saline every day, which takes time, or their pulmozyme, which is or their inhaled antibiotics. So this is one of our patients from our clinic, a 22-year-old whose FEV1's 92% are predicted, who really did not want to do their medicines. They always said, I have mild lung disease. I don't really need this. I'm lucky. They've always been told their whole life, I have mild lung disease. And so it was a real struggle to be able to do their medications. This is one where actually looking at a picture and seeing the amount of lung disease which was hiding behind that FEV1 that's considered to be pretty good. This person actually put this on their refrigerator as a way to inspire them when they didn't feel like doing this. Now, there's lots of different versions of this, but the idea of having some sort of feedback, particularly with your child, that's visual, can be very effective. We've ended up using a good amount of CTs. At the end of the day, I think you also, this is what we give to our patients at the very end of each visit, a plan. So you want to have a list and saying, okay, we've talked about this. What's the plan from here? Over the next couple months, what do we want to be doing? We'll try to also write what their baseline FEV1 is, what their lung function is here. If nutrition's an issue, we'll talk about their weight and their goal weight. Obviously, if there's other issues. But at the very end, you want to sort of have that clear plan for the upcoming months that's based on the interaction during clinic. The other one that I'll mention that we're using more and more, which you might find helpful, is using home FEV1 monitoring. So you think about this, we come quarterly, you get a lung function, you sort of focus on that. Is it good? Is it bad? Where do we stand on that? And then you say, okay, then in the next couple months, we'll sort of do our stuff and we'll wait for another measurement. There are home spirometers that are available now where you can actually measure your FEV1 each day or frequently just to keep an eye on that. We actually have an R01 research grant going on at Hopkins in conjunction with Seattle right now, which looks at home monitoring, trying to identify exacerbations sort of earlier on to see if we could treat them. And this is just an example. This is actually a real spirometry from a patient who was doing this. And they brought this in and we looked at it together. And I said, what in the world happened here? And she said, let me look back. So she looked back, and it was actually the day that she had started hypertonic saline. So she was not entirely convinced. She said, it makes me cough a lot. It's sort of done some stuff. But it wasn't actually until she printed this out for clinic that she said, wow, okay, I guess I will keep doing that, because you could see this dramatic effect. We've also seen the reverse. This was actually that same patient. Here at one point, I'd been sort of pushing her to do her inhaled tobramycin, and she said, I don't feel so good on it. And it turns out she was actually having bronchospasm with it, so that when she started it, we actually were doing her home monitoring, and she actually declined quite a bit. Now, we've seen the opposite in some other patients who they've actually gotten better while on inhaled tobramycin, and either way, it's obviously important information to have. So something to think about, and not that expensive. The other thing is, from these benchmarking study that we say, centers with best outcomes are kind, but not too nice. Now, what does that mean? You know what? We all want to have visits that are happy, right? The clinic visits where everybody says, oh, that's great, no cavities, whatever, go home. It's you're doing great, you're doing your medicines, your lungs function's the best it's ever been. But the truth is, you can't always have that. And so in those situations, you want to be able to say, what do we need to do? And not be afraid to interact. So centers with best outcomes have a pretty aggressive attitude to treatment. And that's going to be the same thing with families and with patients. So when we see that there's a decline in lung function, persistent increase in symptoms, we don't want to sit on that for too long, right? We know that that results in loss of lung function. So this means having a team. These centers that did well had teams that were very aggressive, but also patients and their families who sort of bought into this idea of not sitting on symptoms for a long time, reporting them early, and trying to get an intervention. And the other thing was actually not hesitant to use antibiotics. There's 2 studies which I think highlight the importance of being aggressive with antibiotics when appropriate. This is actually one from Chest in 2003, which did something similar. They looked at the top quartile centers for FEV1 and tried to look at some of their treatment trends and how they were different from other quartiles. And three things jumped out. One was that these top quartile centers actually used more frequent IV antibiotics, particularly in teens with only mild to moderate lung disease. Now, if you think about it, this is actually opposite of what you'd think. Because if you had a group that's FEV1, a center whose FEV1 is actually better than everybody else's, you would think they're more mild. They don't need to use IV antibiotics as much because they have more mild lung disease. The opposite was true. That group with better lung function actually ended up using more IV antibiotics, being more aggressive, suggesting that maybe this in and of itself that might be contributing to some of that lung function. They tended to do more frequent spirometry, more frequent cultures, basically being aggressive and identifying problems. And then longer courses of IV antibiotics, particularly in adults. I'm just going to share one thing that highlights some of the attitudes toward antibiotic use. This is actually from some of the surveys that we sent to centers that were at the top quartile and bottom quartile, and asked basically, not in order, but sort of buried into this very long questionnaire, a couple of questions asking basically the same thing, and that is how aggressive they were with antibiotic use. So we asked the centers, how likely are you to be conservative with antibiotics to avoid development of resistance? So we're trying to say, are you afraid of using antibiotics? How likely are you to use antibiotics to treat common cold symptoms? And then lastly, the number of days that you would normally wait before prescribing antibiotics for somebody who says they have symptoms. The key thing is in every question, the top quartile centers actually were not afraid of using antibiotics. They were more likely to use antibiotics for sort of common cold symptoms, which we know sometimes are actually CF symptoms, and that they had a much shorter length of time before they were willing to prescribe antibiotics. So I think this highlights this idea of wanting to be aggressive with patients when they have symptoms. So I think as patients and as parents, we want to take that same approach that we talked about that was successful in these centers to try to be aggressive with addressing this. The other thing was that patients don't allow long stretches of missed clinic visits or medications. So I put this up here because normally we say we want to have 4 visits or whatever is appropriate, but the idea of having long stretches where you don't go to clinic or long stretches where you miss your medications were associated with more trouble. Real life means that there's going to be times you miss your medicines. The key thing we always talk to our patients about is not letting that add up to be a persistent thing and making sure that that doesn't drag on for too long. Another thing which stood out was this idea of making it personal. Now, what do I mean by that? We know there's lots of obstacles to adherence, all right? So people will say, what's the secret to good medical adherence? There is no secret. Everybody's different. Everybody has different reasons why they struggle with this. And so part of this is going to be figuring out what are some of these specific things. Sometimes it can be financial issues. This comes up all the time. Sometimes it can be anxiety or depression. Okay, obviously the treatment for that is going to, or the approach to that's going to be very different. We see this all the time, that somebody doesn't want to do IV antibiotics, doesn't want to do a medication because they say, I have this vacation coming up. Summer's perfect for that, right? I have this trip coming up. I don't want to have to take my medicines then. Or I've got the prom coming up. I can't do IVs right then. So you want to think about how you can negotiate around these. And then sometimes it's fear of certain medications. I read this on the internet. I heard it's a bad, I heard about trouble with this from this one patient. Wanting to be able to talk about this, or embarrassment, not wanting other people around them to know. So I think what we say to our patients when we have new patients, the key thing is be honest. There's nothing that you can say that we haven't already heard. We'd much, much rather you be honest about what's really going on, because otherwise our approaches tend to add more medicines. If you're not really taking them, the last thing we want to do is to add more medicines, right? So we want to say, tell us what you're really doing. How can we address this? If there are barriers, financial ones, sometimes that's embarrassing to bring up. You can't afford a copay. There are a lot of programs out there now to help with copay problems. Or life events. You want to be able to sort of talk about how to work around those. We do this all the time. We say, okay, you have the prom next week. All right, you know what? How about the Friday or the Monday after the prom, let's go ahead and get this started. Come into the hospital. But that way they feel like they're going to be in some control as they do this. And then it also helps because then when there are times when we say, no, you need to do this now, they realize that's not always the answer. That sometimes we say it's okay. And then in adults in particular, anxiety and depression is a key thing. We're beginning to see more and more that this can be a big barrier to adherence. Okay, so I think at the very end we want to end up with a partnership which allows us to get the best care. And then the last section, just want to talk about some strategies to help young people with CF become successful adults with CF. 10 minutes, perfect. Okay, so this is actually one of my favorite figures. I should probably try to get an updated version of this, but it's so good I just keep putting it up there again. This is actually looking at the severity of lung disease of 18-year-olds as they transition to, or 18-year-olds in general, but as they're getting ready to transition to adult care. Green means mild lung disease and FEV1 greater than 70. Blue means moderate, between 40 and 70%. And red means severe, with an FEV1% predicted below 40%. So this is a lot of good news, right? That each successive 5-year period, and even in 2007, there's been better and better lung function in 18-year-olds, to the point that if you look at 18-year-olds now, it's actually well below 10% of 18-year-olds that have severe lung disease, meaning FEV1 below 40%. That at the same time, we still have to be careful. This is actually looking at analysis of patients by age who lost more than 5% of their lung function in the previous year based on the CF registry. 5% of lung function loss, that's a lot. I think we'd all agree that you would agree that you want to avoid that. But the areas where there's the most lung function lost tends to be in this late teen group. This is a group that's starting to grow up, going away to college, have the prom going on, be busy, be embarrassed about something, with their friends. So this is a group that, despite this idea of 18-year-olds doing better, we still have a lot of work to do in this group. And this is a group that I want to talk about how we can prepare. It's also a group that tends to come to clinic less, particularly as they're getting up here. This one option is just to do this. Actually, my daughter, my 16-year-old daughter is here right now. She's never made me do this. Yeah, maybe once. So here's the good news, though. What we do in the pediatric years is actually going to predict how our patients do as they get older, or how our children do as they get older. And how do we know this? During the benchmarking analysis, we actually looked at the top 10 adult programs we said corrected for FEV1. And the interesting thing is, even after you correct for their FEV1 at age 20, 7 of the top 10 centers for adults were ones that also had the top 10 for pediatrics. Now, why is that? Because we're actually correcting. We're putting everybody in equal ground at age 20, but going forward from age 20, they tended to come from centers that also had good lung function. That's probably because the habits that they've learned during those pediatric years carry over during those later years. We know that for everything in life, right? Sort of what we learn. And so I think what we want to talk about is how can we start developing those habits so that they carry over later on in life. So I think a couple of principles here. One is we have to start thinking about the transition to adulthood as a gradual process that doesn't start at age 18, but starts during the early teen years or younger, right? Just like we have with all the other things in life that we're trying to teach our kids. So it's not a transfer at age 18, like, oh, time for the adult program, but something that we're building on as they're getting older, starting early. The other thing is that parental guidance is essential, but it's absolutely essential that you not do everything. Otherwise, disaster is on the horizon. I'm telling you. This is actually, I don't need to quote, everybody knows who John Wooden is around here, famous basketball coach at UCLA, probably considered the best college basketball coach of all time. I love this quote of his. He said, "The worst thing you can do for someone you love is to do that which they could and should do for themselves." This is particularly true in something like CF as you're getting older. There's always that balance, but if you're doing everything, that's going to be trouble. So this is a very advanced scientific graph of the ideal transition to adult CF care, which required years of preparation. Less parents, more child, somewhere in here. But it's just something to be thinking about, all right? So one of the things that we've done is to try to at least think about some goals. And this last little section here, talk about some goals. And everybody's a little different in terms of the right age, But I think the idea is trying to have your individual, your child with CF, assuming more responsibility so that when they do leave the home, they actually have some skills to take with them. So our goals for 12-year-olds is really just to know what CF is, to be able to name their medications, why they take them. Remember to take enzymes. That's a good initial responsibility. This is the toughest one, but remember to do some airway clearance, maybe most of the time, but just this idea of, hey, what are you supposed to do there? As they get a little older, to list their medications, to be able to know sort of when they take them and the amounts. This is a big one, to start having where they answer some questions in clinic. Now, I'm not a pediatrician, but it's something we talk about at our family day every year, this idea, and our pediatricians have been very good at this, of starting to say it's not just the parent answering the questions, but it's they start having the youngster with CF be able to answer some to feel comfortable with this. And this is another one, big one, recognizing symptoms. Being able to say something's not right, okay? That makes a big difference for everybody. That we continue to stress this one, to be able to recognize symptoms and describe them. So it's a skill to be able to do that as you get older. To describe maybe this idea about smoking, drinking, the effect on health and CF, starting to be aware of the dates of clinic appointments and tests, maybe being aware that the medication doesn't sort of magically appear in the medicine cabinet or in the closet or whatever it is, this idea. And then finally, as you're getting a little older, to be able to speak directly to CF caregivers about discussing changes in health, participate in some scheduling, maintaining own equipment, those type of things. And then finally, the goal would be at age 21 to be able to actually contact your CF caregiver, to talk to them on the phone about that, to schedule some appointments, basically even maybe being aware of some things about insurance, some of those things which are popping up down the road. The other thing is principle 2, and these are the last couple of slides. Remember that it's not just your child who's going through a transition. You are as well. This is not easy for kids. It's not easy for adults as well, but it's really important. So this is another one of my favorite. So you think he's starting to outgrow the stroller? I think I've seen this couple in our clinic. This is one of our patients. No. So anyway, I think you get the point here with this idea of trying to assume responsibility over time. And then finally, principle 3, this is hopefully some encouragement with the idea what the long-term goal is. The long-term goal is not perfection. It's develop a sense of self-responsibility. Nobody's perfect, none of our patients. Even there's some parents who are trying to have everything that are perfect. There's that balance, right? But you can't let that get in the way of trying to assume responsibility over time. So this says, oh boy, you've grown all right. Better be careful though, from now on, they won't throw you back. That's where they're headed, okay? So we want to help them get there. And so in summary then, I think I've hopefully convinced you that what we do does make a difference. What you're working on, what you're struggling to do makes a difference. It's not just genetics. That there's ways that you can partner with your caregiver by being prepared that really will help to make those clinic visits and that care the best. And that there are ways in terms of trying to help our young people with CF to assume responsibility as they get older and not get so hung up on perfection that we lose the ultimate goal, which is trying to prepare these youngsters, these young adults with CF to become successful adults with CF. So with that, I think we just want to say we want to try to head for a real partnership with you guys, and I'm happy to take any questions or suggestions.
Thank you so much, Dr. Boyle.
Yes.
That was really wonderful. I wish I'd had that presentation when I had a 6-year-old with CF. Would have done some things differently. So questions, come on.
It's actually not a question, it's a suggestion.
Great, even better.
How about some geriatric CF clinics?
How long till geriatric? So I don't know if everybody heard that. They said, how about some geriatric CF clinics? I forgot. So the answer is a great idea. We'd love to have that. Any geriatricians in the audience? Because we do have a couple people who would qualify. We wouldn't even have more.
We have a very independent young 26-year-old who does a tremendous amount of traveling. Her biggest problem managing her health care is she's only in the area a couple months out of the year in a single block. and her doctors are frustrated. I need to see you more often. So her suggestion was, I'm near major adult CF centers in the country. How about we ship stuff there, and I get kind of checked up all over there, and they're not too sure. So
yeah, what's my thought? So,
give me your opinion.
Well, no, this is a challenge, and it comes up all the time. I mean, this comes up when you go to college as well. How are you going to do your care when you go to college? And there's different ways of doing this. I think we definitely have used the model sometimes where we have 2 centers, because people will go, let's say they have a home, and during the school year they're in another place, and what we do is suggest that they get tied into one center that knows them well. I think when you start having multiple centers, it doesn't work. It just doesn't. So when we have patients that show up, we have occasion they'll say, oh, I'm coming to Johns Hopkins. So they'll show up, we don't know anything about them, they come, we're not going to see them again, or we're going to see them again in a year or 2. I don't think it's the best care. So I think there's ways of maybe having a couple of home bases, but I don't think it works to have 4.
She only has 1 home base. The rest of the time she's traveling. So if you don't think that works, how about if she can set up spirometry periodically, so at least they have 1 measurement to look at?
Yeah, so maybe a home spirometer would make sense for there. I think it's hard to show up at several centers. It's hard for the care team, it's hard for the person. It's sort of a grab bag. Maybe, like I say, a home base and a college base, or a home base and a frequently visited base might make sense, but I think it's going to be a struggle to do more than that.
Hi. You talk about IVs or antibiotics for even mild declines. My question is, what about some of the off-label inhaled antibiotics? And so many of the studies were done before there were many options with inhaled antibiotics. Is there any change in thinking on sort of more aggressive use of those, and particularly for exacerbations?
Right, so I think the specific question is best ways for using inhaled antibiotics? Is that? Oh, I see. Are inhaled antibiotics an alternative to IVs? So I think it depends on the setting. So the answer is inhaled antibiotics are a lot easier in one way because they don't need IVs. So we usually think about IVs as when the other things won't work well. Inhaled antibiotics, there's 2 different ways. This could be a whole talk, literally, but one of those is for maintenance. And there's been numerous studies now which show that chronic inhaled antibiotic use helps maintain lung function. We tend to do 1 every other month. We do it every other month initially and a month off. But more and more we've been actually adding some other inhaled antibiotic during that off month, so maybe alternating Caistin and inhaled tobramycin or Toby. There are... What's that? Yeah, so that's, there's the other one that used to be in there mixed in as well as colistin. It probably has less data in terms, or definitely has less data in terms of being studied, so it's probably our 3rd line. There was a little bit of experience with some other inhaled antibiotics as well in there, but I don't know if I can give you one set answer. We tend to try to be aggressive with that. There are certainly times when somebody comes in more sick. If they're not on an inhaled antibiotic, we'll combine that with an oral agent like a fluoroquinolone, Cipro, or levofloxacin, something like that. If that doesn't work, we sort of think about that treatment ladder. So if that doesn't work, then go to IVs. I don't know if that's answering your question, but I think being aggressive with inhaled antibiotics to maintain lung function has been demonstrated to be helpful, for sure. The question is how often. Depends a little bit on what part of the world you get cared for in. Yes, it's a good thing.
So I have 2 questions. One, you mentioned for adult CF patients, they should, be aware of their data and all that.
Yes.
I was wondering to what extent do you think we should be aware and should we know all the details of this, whatever? Because I know I do a lot of blood tests and there are all these numbers and all these letters, and I can't really keep track of it very
well. Well, here's the good news is I don't think your job is going to be the physician or the nurse. And so, but, if there's any place that demonstrates how involved patients and families can be, it's here, right? And so people are incredibly well educated. They understand the issues. I don't think, so there's a fine line because it's helpful when somebody comes in and they know the key issues, ABPA, you're checking your IgE, you're looking at your lung function, your FEV1. It's not if you say, well, what about this potassium or this phosphate, so you have a list that's 700 long, because it's easy to get lost in all those little details. So I think it's starting to understand and work with your care team, what are the key things that I should be following? And maybe not obsessing about every little single detail, because otherwise you get focused on something that maybe not be that important. So everybody has a different way of approaching it. I say work with your team to identify what are the key things. I listed some of those things. So it's probably lung FEV1, it's probably your microbiology, it's your nutritional status, it's maybe a couple of other labs that are an issue for you. That I don't think your job, though, is to have to keep track of everything. That's why you pick a good care team and you work with them. Does that answer your question?
Yeah, and the second question I have, so you mentioned home spirometry tools. I have one, and I think it's really inaccurate, so I was wondering if you have any suggestions for a good one.
So I think it depends a little bit on there are some different types. We can give you some specific suggestions in there. You can actually buy them off of Amazon. That we do not, I think the best thing is if you're using it to compare to yourself. So we don't really use, so you get to know what yours normally reads. And it may not be exactly the same as a full spirometry at a hospital. We're not trying to say it should replace that. But it's something where you're trying to look for a change. There'll be a little bit of variability, and then suddenly maybe you'll see a decline. That just another thing, if you say, hey, I'm noticing a change in symptoms, that can be very helpful. I can give you some specific recommendations. It sort of changes every year or two. All right.
Hi. I have a daughter who's 24 with CF, and she just had tons of transitions. One being she got married in October. 2, she moved out here 2 months ago from Chicago with her husband, and 3, diagnosed with the diabetes now. Yeah. But as far as the whole transition experience, she's in that middle ground where she did the transition, but the things weren't in sync at this point because she started when she was like 18. And I think for the newer families, I think it'll be better. I think the groundwork has been laid. But it affected her health. I mean, it really affected her health. Emotionally, physically, every other way. Yeah. But anyway, my favorite story was when she called a few weeks ago and she goes, Mom, you never told me how bad all this insurance dealing was. Like, yeah, well, hello, who do you think was doing it? Yeah. But just real quickly, I wanted to say, too, that she does autogenic drainage. And the reason she does it, her husband's from London. She went over to London, one of his friends who has CF. That's what they do there. There is no vest. She did the vest for years. We did the pounding. We did flutter. You name it. But I really think if people are interested in learning it, especially the teens, it's phenomenal. She does not have to carry anything with her. Yeah. It's part meditation, but I watch her do it. It's so effective. I mean, I think it's fantastic.
That's the perfect segue to our afternoon talk. So, Mary Lester, who is probably as good a teacher of airway clearance in the world, is going to be talking to us after lunch. So are you going to mention autogenic drainage, or can you? Absolutely. So we're going to hear lots of details. So anyway, thank you very much. Thank
you. Okay, we have less than 1 minute of announcements and